My name is Mandisa Zwane-machakata. I'm from SAM4SRHR, Eswatini, which appears as Swaziland in your program. It's the same country, don't worry. I'll be presenting on the digital use of social accountability monitoring for sexual reproductive health rights, which we call SAM4SRHR, as a key strategy to improve uptake of youth-friendly services in Eswatini. So I think we've established already the background around, how we are progressing relatively well in our region towards getting people tested, getting them on treatment and viral suppression. And yet we still have groups that are lagging behind, which include young people. So it's against that background that the application I'm going to speak to was also developed. Eswatini developed youth-friendly guidelines, and all health facilities were trained, and we had focal persons in the facilities to make sure that the rollout of the guidelines continued. And yet we found that even where a facility was trained, where the healthcare workers were friendly, young people were still going further to other facilities to access services. They still didn't have the confidence to use their local health facility, which affected adherence, it affected uptake of services, and it affected how they were able to access services in their community. The Mobi Surface application is a web-based and also application-based application, which can be found on Android. Sorry, iPhone users. Yes, it can be found on Android and can actually be shared through ShareIt, but it's also web-based. So you can actually access it on your laptop or computer. And what we've done with it is when the application was developed, we capacitated the facilities with tablets that are placed in each facility, in the youth-friendly corner with the application. The application basically empowers young people to be able to give feedback on how they're accessing services and to actually say whether the services are youth-friendly and whether the services are meeting their needs. If they are not, they're able to log what we call an issue or a ticket on the application, and it is actually received in real time by the head of the facility. The way that it's structured is such that if a young person goes into a facility and accesses a service, I'll use myself as an example. I can log into the application, register. I do not have to say I'm Mandisa. I can say I'm Thick Mandy, Marvelous Mandy, or whatever I want to call myself if I want to be anonymous. And then if, for example, I've had an issue with accessing my choice of family planning commodity and it wasn't in the facility, I can then log that into the application to say I came in for family planning of a particular, for example, I wanted the implant but I didn't get it. And then at the moment that I put in and I click send, it goes to the head of the facility to let them know that a young person has come in with this issue. And then immediately the head of the facility gets a notification, to which she then responds by sending to one of the service providers within her facility, whether it's a focal person or whoever it is, and then that person must attend to that issue. Once the issue has been resolved, the application is then, a message is then sent to me to say your issue has been resolved. I can then go back to the facility to say yes, my issue has been resolved and close my issue or my ticket. Or I can say it has been resolved but not to my satisfaction. I have a further issue on it and then log that as well. This slide actually speaks to that initially when we started it, it was an implementation science research pilot where we worked in a few facilities. We tried to target facilities that were outside of the DREAMS and Global Fund coverage so that we were reaching young people who were not already filled with access to services through mobile services and other approaches. The approach also includes strengthening the community component of service provision by working with youth networks in that particular region or area, as well as working with service providers. And then from there, once the pilot has been put into place, we then look at the data that comes in periodically. The facility is encouraged that each time that the issues come in weekly, they must, through their weekly meetings, review all the issues that came into their facility that week. And once they do that, they're able to read them, they're able to resolve them as a facility. That way, the whole facility is aware of the issues that are coming in from the young people that are their clients in that particular area. The methodology, as I mentioned, was looking at targeting health facilities that were outside of the DRIPS and Global Fund coverage areas. Tablets were placed in the health facilities. Young people were also given access to the application because you can download it from the Play Store if you have a smartphone. They were also trained to become champions in order to recruit other young people to take up use of the application. And then we trained also the healthcare workers on the use of the application. While initially what we wanted to do was give client feedback, we also found that another result of this application is that we saw that it increased the use of the local facility by young people. In some facilities, usage actually went up by 4 times, which meant that when young people got the power to be able to give feedback, they gained more confidence in their facilities, and they actually went back to using those facilities. I'm not going to go into the data because I can see my time is already being mean to me. But in conclusion, we found that utilization of social accountability monitoring actually empowers young people not just to give feedback on how they're accessing services, but it also gives them confidence that when their issues are reported, they will be addressed. And it strengthens the linkage between the community and the facility, because once the young people have confidence in the facility, they return back to the facility that is closest to them, which can actually have better outcomes for us in terms of adherence and ensuring that utilization of services in the coverage area where they are is actually met. I know it was quite a mouthful. I'm just in time. I'd like to acknowledge UNICEF, who is funding us to upscale the approach to the 15 facilities we are working in now. The government of Eswatini, the Ministry of Health in particular, because they are the ones who adopted the application and ensured that it is now being upscaled. We also would like to acknowledge Sweden, as they were the initial funders of the pilot and developing the application, as well as SAFAIDS, the organization that is working in this area. Thank you.